life and career as an elected representative dating back to my first term on the Boston City Council. Looking at something is also a nod to the power of representative government and that we have an unprecedented number of women currently serving in Congress, more than ever has served in the history of Congress. More women and less diverse group of women. And I remember my time on the Boston City Council as the first black woman to serve on that body. During our budget cycle, I asked every agency and department before us, from schools to healthcare to our court system, what about the girls? And their responses were monosyllabic. They had lengthy testimony and unit reports focused on boys and men, and no answers on the impact on our young girls and women. But I kept calling the question. And that is the power of your Democratic Women's Caucus. And we are daily calling the question. And that is truly the power of a representative government. You have a diversity of perspective, opinion, and thought. When the issues being championed, the solutions being developed are not being done through a myopic or homogeneous lens. The unprecedented health trauma and grief that our young girls are carrying in their emotional backpack weighs heavily on them. And with the multi-layered crises facing them, a CDC study found more than half, 57% of teen girls, felt persistently sad or hopeless. The mental health crisis afflicting our young girls actually demands congressional action. Key investments in schools, the healthcare workforce, and more are necessary to meet the moment and to provide the nurture and care that every little girl deserves. It is our job to deliver. So I stand ready to hear from the experts today to explore the contributing factors to this epidemic and to develop solutions to support our girls, our LGBTQ+ youth, our girls with disabilities, and our girls of color, and others representing multiple marginalized identities. I would like to now recognize my esteemed Democratic Women's Caucus policy co-chair, Congresswoman Kathy Manning, for her opening remarks, and to introduce our panel of witnesses.
Thank you so much, and I am delighted to see this room full of people who've come to this very important hearing on a critically important topic. I want to start off by noting the deep importance of the issue that we will be discussing today. Mental illness is typically considered an invisible illness, and right now we are experiencing an epidemic of this invisible illness. And this invisibility affects teen girls in particular. And as my esteemed colleague just noted, earlier this year, the CDC found higher rates of suicidality, depression, and sexual violence among young women than their male counterparts. Girls report more drastic mental health impacts from social media. We know from not just these reports, not just the CDC study, but reports we read all across the news that social media is having a terribly negative effect on teenage girls. These girls that we're concerned about are our future leaders. I certainly hope that someday many of those girls who are out there experiencing this kind of mental stress will be in this room, sitting on this dais, and perhaps someday in the Oval Office. So to hear more about what our girls are experiencing, we have a panel of fantastic witnesses. First is Mary Lawal, a youth mental health advocate and a student at Prince George's County Community College. She will speak to the lived experience of the current youth mental health crisis. Mary, we're so glad you're here. Next, we have Hannah Wesolowski, the Chief Advocacy Officer at NAMI. Ms. Wesolowski is a long-standing healthcare advocate and has over a decade of experience of political advocacy, and we welcome your voice today. We're also joined by Dr. Celeste Malone, an associate professor and school psychology program coordinator at Howard University. Dr. Malone holds leadership positions at the American Psychological Association, the National Association of School Psychologists, many state-level professional organizations. And finally, we have Dr. Tammy Benton, the president-elect of the American Association of Child and Adolescent Psychiatry. Dr. Benton was previously the psychiatrist-in-chief, executive director, and chair of the Child and Adolescent Psychiatry and Behavioral Sciences at the AACAP, and has dedicated her career to pediatric mental health. Thank you all for being here today, and the chair recognizes Ms. Lawal for her testimony.
Good afternoon, Congresswoman Manning, Congresswoman Pressley, and the other members of the Democratic Caucus. Thank you for inviting me to speak today. My name is Mary Lawal, a youth mental health advocate and speaker. I volunteer for NAMI Metro Baltimore as a support group facilitator and an Ending the Silence presenter, where I get to share my mental health story. I began having a burning passion for creating awareness surrounding mental health and fighting against stigma when I got diagnosed with bipolar disorder and borderline personality disorder, which I am now in recovery from as of this year. As a girl child, growing up, I experienced trauma. I felt alone, confused, and misunderstood. I remember desperately needing someone to talk to, someone that might help me understand what was happening, or at least someone to listen. I wanted someone that might help me know what was happening, because I knew it was getting bad. I thought to talk to a professional at school because I knew that I needed help, and I didn't know mental health services were an option for a young African American female child. As I heard many times people around my community and support network, she's just a moody teenager. It's just the hormones. She's only acting out for attention. Someone must have gotten her period. I felt dismissed and invalidated. We did not have a mental health counselor or therapist in school. All we had was a guidance counselor who focused on making sure our grades were good and we were staying out of trouble. At my church's youth retreat, there was a workshop discussion held for teen girls ages 13 and up. Silver Ndom, 13 years old, opened up about her experience and how she felt during the COVID-19 pandemic. She explained as she broke down during the pandemic, it was one of her lowest times for her, because she had felt burdened by the pressure that she felt as the oldest sibling at home, having to cater and look after her siblings, cook, clean, do laundry while still attending online classes and studying. She couldn't talk to anyone about the way she felt because she wasn't sure who to talk to, and she wasn't sure who to talk to, and this led to her feeling suicidal. And her parents provided her no support or an open outlet for her to share what she was feeling. These are some of the things teen girls, especially of color, face in their households. They are left to fend and cater for the household and are left with the burden and responsibility of taking care of their younger siblings. According to CDC, teen girls are experiencing record high levels of violence, sadness, and suicide risk. School students with depression are more than twice likely to drop out more than their peers because of the burden they face at home. School no longer becomes a priority. We need mental health services to be put in place in learning environments to give students, especially teen girls, the opportunity to open up and feel heard about the struggle they might be facing, and to point them towards available resources. This will create a space where students feel understood. It will also help a lot of students who battle with their mental health and have mental health challenges or conditions get the help they need on time. 45.5% of Marylanders ages 12 to 17 have depression, did not receive any care in the last year. The pandemic has left students feeling depressed, isolated, and traumatized. In 2021, I was in and out of the mental hospital. As I was in the ER, I had to wait 13 hours to get the help I needed. I wasn't seen by a counselor or psychiatrist. I kept having breakdowns, and my mom had to calm me down. I felt, what was the point of going to the hospital when I couldn't get the help I needed? I felt like, what was the point? Where else am I supposed to go to if I can't get that help? There is a drastic lack of mental health resources, prolonged wait times, and a huge surge of bed space available to cater to patients in need of mental health services. We need a plan in place to ensure youth and young adults are getting in the doorway of getting the support and resources they need, even before reaching a crisis point. I have found 988 to be extremely helpful and valuable to me when I find myself in a crisis situation, but feel overwhelmed and hopeless, but want to stay out of the hospital. I dial 988, then get connected to a crisis counselor who makes sure I don't have anything on me that can potentially use to harm myself, then assist me in coming up with a crisis plan to keep me safe until I am able to go to my therapy appointment the next day and avoid hospitalization. 988 has been my go-to for when I can't seem to de-escalate because it is such an easy number to keep at the top of my head, even when I can't process anything. This new suicide prevention hotline has been an incredible tool for me and a resource for me and many others who struggle with their mental health and keeping themselves safe. I was previously on the sponsor panel to share my testimony with legislators at the Annapolis bill funding for the 988 Mental Health and Crisis Hotline. My hopes are that 988 will remain an easy and accessible resource for me and youth, and then youth care will continue to improve and will be more in reach to those affected. Thank you for listening, and I look forward to your questions.
Thank you so much for your testimony. Now we'll move on to Ms. Wesolowski.
Thank you so much, Congresswoman Pressley, Congresswoman Manning, and members of the Democratic Women's Caucus. On behalf of the National Alliance on Mental Illness, I want to thank you for your focus on our country's mental health crisis, particularly among teen girls, and I'm honored to be with these amazing women today. NAMI is the largest grassroots mental health organization in the country, and we're dedicated to building better lives for the millions of Americans who are affected by mental health conditions. The problem in front of us is a big one. 1 in 5 people right now have a mental health condition. 1 in 2 people will face a mental health condition at some point in their lifetime. NAMI believes every person deserves the opportunity to lead a healthy and fulfilling life. Unfortunately, our current mental health crisis and the lack of access to care poses an unprecedented threat to the opportunity for many of our young women. Earlier this year, the Centers for Disease Control and Prevention released the most recent Youth Behavior Risk Survey. The data was collected in 2021, and it paints a stark picture of teen girl mental health. The bad news is that all teens are experiencing worsening mental health conditions. The horrifying news is that the data shows that teen girls' mental health is far worse than boys on nearly every point. 57% of teen girls felt persistently sad or hopeless in 2021. That's double the rate of teen boys and a drastic 60% increase over a decade ago. Shockingly, 3 in 10 teen girls seriously considered suicide in 2021. That's, again, a 60% increase over the last decade. 1/4 of girls made a suicide plan, and 13% of girls had 1 or more suicide attempt in 2021. Again, almost double the rate of boys. Every day, NAMI's helpline receives calls from people who are desperately seeking mental health resources and support. This month, we launched a teen and young adult helpline to provide a safe space for young people to connect with other young people when they need help and support. We always say NAMI changes lives while we wait on the world to change, because finding care is a battle. 75% of mental health conditions will first appear by age 24, but it takes, on average, 11 years for people to get treatment after their symptoms first appear. 11 years. Only about half of youth aged 6 to 17 with a mental health condition receive treatment in any given year. We wouldn't accept this for any other health condition, and we shouldn't accept it for our kids. We are foregoing our girls' future. Untreated mental health conditions in children and adolescents are related to adverse health, academic, and social outcomes, and higher levels of drug abuse, self-harm, and suicidal behavior. Ignoring the problem now doesn't make it go away. It just causes it to balloon and worsen well into the future. The reasons we're seeing this are complex. COVID-19 had a disproportionate impact on our youth, and particularly teen girls who, on the whole, felt the impact of being disconnected from their in-person social network more than teen boys. The true impact of social media is unknown. For some people, it gives them a community for support and connection, but for many, it can be a platform for bullying or a tool that diminishes their self-esteem. Tie that to the upheaval in the world right now. We have wars in the Ukraine and now in Israel and Gaza. Climate change is a threat that causes anxiety over the future. And anti-LGBTQ+ rhetoric creates an environment that even if a person doesn't identify as LGBTQ+, creates concern over friends and loved ones and puts forth a narrative that there's a right way to be. I'm the proud mom to a young daughter and a proud aunt to 3 wonderful girls. I'm terrified for what their future might hold. How will the world's challenges and their environment affect them? When they need help, will they be able to find it? My fear is that they won't. So what can we do? We need to prioritize prevention. We need better mental health screenings. We need to teach kids the tools to self-regulate and to identify conditions earlier. We need to remove barriers to care that make it easier for young people to receive mental health care. That starts by making it more available in the places where our kids are, pediatricians' offices and in schools, so we can intervene early. We need to hold health insurance companies accountable for making mental health care more readily available. Right now, nearly 70% of kids seeking mental health and substance use care did not receive any care on at least one occasion during the last year, compared to only 20% for physical health care. But none of that matters if people don't know what to look for and don't know where to turn to. So we need to eliminate stigma and normalize mental health. We need to treat what's going on above our neck the same as how we treat what's going on below our neck. We cannot risk our girls' future. We need to give our girls every tool and resource to have a healthy and fulfilling life. Thank you for your time today. I look forward to your questions.
Thank you. I'll now recognize Dr. Celeste Malone.
Good afternoon. My name is Dr. Celeste Malone. I am a school psychologist, professor at Howard University, and immediate past president of the National Association of School Psychologists. Thank you for your commitment to addressing youth mental health and highlighting the unique needs of adolescent girls. I appreciate the opportunity to engage in this dialogue. While much attention has been paid to youth mental health in the aftermath of the COVID-19 pandemic, the truth is the United States has been teetering on the brink of a youth mental health crisis for years. Prior to the pandemic, 1 in 6 children had a diagnosable mental health disorder, but only half received mental health treatment. According to data from the Youth Risk Behavior Surveillance System, almost all indicators of poor mental health and suicidality have increased from 2011 to 2021, with these trends especially pronounced among female students. Looking at gender in isolation presents an incomplete picture and assumes that all girls experience the same vulnerabilities and mental health challenges. Racial and ethnic minoritized students and LGBTQ+ students also experienced significant declines in mental health over the past decade. It is imperative that we examine mental health data with an intersectional lens to identify those girls most vulnerable to mental health distress and enact policy and practice that address their unique needs. The state of girls' mental health writ large is distressing. However, it is worse for girls of color, those who identify as LGBTQ, trans, or non-binary, and girls with disabilities as compared to their white, cisgender, heterosexual, and non-disabled peers. The unfortunate reality is that some girls are deemed less worthy of protection and support because they do not fit within traditional feminine gender norms. For example, in schools, Black girls and LGBTQ+ girls are disciplined more frequently and more harshly compared to other girls and most subgroups of boys. These girls face increased scrutiny from adults, are punished when their dress and self-expression do not conform to gender norms, and are assumed to be the aggressor in situations where they are defending themselves. At a time when these girls are experiencing mental health distress, they are targeted for punishment instead of support. As a Black female mental health professional and university professor, it is my privilege and responsibility to train culturally competent school psychologists prepared to address the mental health needs of all students. Many of my research advisees are Black women with a specific interest in addressing Black girls' mental health because of their own experiences navigating K-12 schools. We talk about how the Black girls at their practica and their internship sites see them as role models and specifically seek out their services. Our lived experiences as Black women provide us with a unique lens to recognize the humanity of Black female students and motivate us to develop interventions that allow these girls to thrive. Now, more than ever, we need to increase our investment in girls' mental health. As members of Congress, you have the ability and responsibility to invest in efforts that will improve the mental health outcomes of our young people. For many communities, schools represent the only option for mental health services. However, we have a critical shortage of school psychologists, school counselors, and school social workers. It is imperative that we address these shortages and increase the diversity among school mental health professionals. This requires sustained investment and action at the local, state, and federal level. And I urge you to work with your colleagues to ensure that the FY24 appropriations bill and all future spending legislation contains robust funding for the Mental Health Services Professionals Demonstration Grant Program and the School-Based Mental Health Services Grant Program to both allow for continuation of existing grants and new awards to increase the capacity of more communities across the country. Thank you, and I look forward to our questions.
Thank you. We'll now recognize Dr. Benton.
Congresswoman Pressley, Congresswoman Manning, and members of the Democratic Women's Caucus, the American Association of Child and Adolescent Psychiatry, thank you for hosting this hearing and the opportunity to share our thoughts on the root causes of mental health crisis among teen girls with a specific focus on solutions. And thank you to my colleagues for laying out the landscape so I can try to make the time requirement. ACAP is the professional home for more than 10,000 child and adolescent psychiatrists and trainees, all of whom work in every child-facing system of care in every community and across the patient's lifespan. We've been on the front line throughout the pandemic and before. In October of 2021, ACAP, along with the Children's Hospital Association and the American Academy of Pediatrics, declared a national state of emergency in children's mental health. We all know that the pediatric mental health pandemic has been longstanding. And to echo my colleagues' concerns, they disproportionately affect minoritized populations, and COVID just made it worse. Complicating these situations even further is the shortage of mental health care providers, and these shortages are well documented. What is not documented is the effect upon the morale of children and families, communities, and clinicians like myself who care for patients who are struggling with their mental health. I've seen more near-fatal suicide attempts than I have in my entire 30-year career. Girls report more intimidation, bullying on social media. Families and communities report more distress related to their children's mental health and lack of access to services. But access to mental health care where children are every day can help address these challenges. Unfortunately, the workforce shortages, the stigma, and funding challenges pose some barriers, but there are solutions. ACAP recommends that Congress pass House Bill 2801, the Kids Privacy Act. That bill allows families to provides them with tools to protect their children from predatory practices by online platforms. Related to the workforce issues, ACAP recommends passage of the bipartisan Resident Education Deferred Interest Act and the bipartisan Mental Health Professionals Workforce Shortage Loan Repayment Act. Those acts allow residents in training to defer interest on their loans while they're in training, and allows people to work in underserved area with loan repayment for a period of time after graduation. ACAP calls on Congress to pass the bipartisan Conrad State 30 and Physician Access Reauthorization Program, sponsored by Congressman Snyder and David Valadao. This would extend and expand the Conrad 30 waiver program, which permits foreign physicians to remain in the United States if they are willing to work in a medically underserved area for a period of time. In order to increase access to care, we ask that you support the expansion of telehealth, particularly telepsychiatry. It was another win during the pandemic. It allows us to extend access to care and to reach areas that are geographically isolated and pretty much serve as mental health deserts. Telehealth is effective and acceptable to families and providers. And we would ask you to support expansion of the child psychiatry access programs, also known as CPAPs, in which pediatricians can have immediate consultation with the child and adolescent psychiatrist about the care of their patients with mental health needs. The CPAPs have been implemented in most states throughout the United States, but we strongly support that these programs be in every state with sustainable federal funding. We also ask that you support the collaborative care programs, the programs that allow mental health professionals, psychiatrists, psychologists, social work therapists to practice alongside pediatricians in their primary care offices. And finally, we ask you to support the Mental Health Services for Students Act of 2023, proposed by Congresswoman Grace Napolitano and Congressman Brian Fitzpatrick. The good news from the CDC report for 2023 is that school connectedness and belongingness supports mental health. So this is an easy win. This legislation would provide on-site school and community-based mental health services. It would support training in public schools and would support community connections for follow-up care. To help to address the growing mental health crisis in teens, we need to meet children and adolescents where they are. Meeting young people at the right time, at the right place, in the right setting will help eliminate barriers to mental health and behavioral health care. We appreciate this opportunity to provide information to the Democratic Women's Caucus on our clinical perspectives and potential solutions to increase access to care, and look forward to our discussion. Thank you.
Thank you, Dr. Benton. Thank you to all of our witnesses. Before recognizing myself for 5 minutes of questions and hearing from my co-chair, also for her own line, I am going to defer to a sister colleague here who is short on time, but it was a priority for her to be here today, and so I will defer to Rep. Lee.
Well, thank you, Madam Chair. Thank you so much, and thank all of you for being here. This is such an incredibly important topic, one as the mother of a young woman, very personal to me as the friend of parents who just lost their daughter to suicide, one that unfortunately is very tragic and personal as well. But prior to coming to Congress, I ran communities and schools in Nevada, and talking about community-based, meeting students where they are and providing that one-on-one relationship and mental health services at school is incredibly important to me. So thank you, Dr. Benton, for addressing that. A recent study shows that 90% of girls use social media every single day. It's less fulfilling than in-person social connections, and obviously contributes to cyberbullying and depression. And tied to that, tragic events that come streaming over children's phone every second of every day, what we're experiencing right now in Gaza, Ukraine. Talk about climate change, you know, they're just getting a sort of flood of information, and it's causing young adults to worry about what their future looks like. I have a teenage son who struggles with depression, and I'm sure that this contributes to it as well. And we need to build more so that children understand we're building a future that they want, but we also need to do a better job of supporting our youth, as you said. Mary, thank you for having the courage and the advocacy to be here. We need to have your voice and voices like yours in venues like this. So thank you for being here. And I just wanted to ask how your peer group consumes the day's news about world events and the threat of climate change, serious conflict, and how do you see this information impacting the peers around you?
Thank you for your question. So I've noticed that there's a lot going on right now, and young adults and young teens are just always on their phone, and we see a lot of the news happening, and it's just so exhausting because I was telling my mom, because she also on the phone all the time, and I was telling her I had to stay off the phone because at this point it's triggering my mental health, and it's just making me feel so, how do I say it? Just making me feel so, like I can't really look at it anymore. Like I had to unfollow a blogger because it was so much sensitive things he was posting, and I just had to unfollow him for the main time because it was so hard to consume all of that information at once. And I feel like there has to be mental health services put in place for young adults, and just young adults are consuming a lot of overload right now in the news and what's going on all around the world. So I feel like there has to be more I'm sorry, I don't know her name, but I'm sorry, I don't know her name. She spoke about telehealth, and I think that telehealth is something that a lot of us need now because not all the time we have the transportation to go to a far location for therapy. So I feel like telehealth, it just helps. It helps because you can do it anywhere you are. If you're maybe on the bus or anything, obviously there's some type of privacy, but there has to be some type of privacy. But the point I'm trying to make is that telehealth, it's very flexible.
Absolutely. Thank you. I want to turn to an issue that has plagued so many in the education settings. There's been 58 school shootings in the United States this year alone. This is obviously a shocking statistic, but this is a threat that just has become a horrific norm and one that I do not want to continue to accept. Dr. Malone, how does PTSD present itself differently in children and teens than adults?
In general, when we think about the presentation of mental health problems, we're often seeing them through an adult lens. But kids, developmentally different in terms of how they communicate, how they're processing emotions and making sense of the world. So there's some overlap, but there are also some very distinct differences that when kids are feeling depressed or sad, it may manifest in behavior problems or frustration or low tolerance. Often a lot of behaviors that annoy and frustrate adults that want them to manage their emotions, be quiet, regulate themselves, and see it more as behavior problems as opposed to interpreting it as emotional problems. And when we think about it from a developmental perspective, again, having the capacity to talk about what it is that is bothering you, because our young people may not actually have the words or language, but it shows up in their behavior. It shows up in physical symptoms when they may speak about headaches or stomach aches, issues of school avoidance as well. And so we need to take the time to have meaningful conversations with kids, give them agency, and recognize their full humanity and not just dismiss their concerns and act like they aren't aware of what's going on in the world. They are very, very much aware. They're overhearing adult conversations, they're overhearing the news, and they're also seeing it on social media. So it's important for us to meet them where they are and to treat them with respect and recognize that they have feelings that need to be acknowledged.
Absolutely. That's such a struggle that administrators and teachers have. Having to meet testing standards, et cetera, hours of instruction, and then being able to take that time to, have that time with people, with students to deal with their issues and to, to de-escalate their behaviors is so important. And Dr. Benton, could you just speak back to gun violence, some of the psychological effects that it has on children and concerns, how these concerns are having effects on teens today?
Yeah, that's a really great question and a really important topic. So I live in a city where there's quite a bit of gun violence, and frequently we're seeing children across the age ranges, including young children, whose parents bring them in because they're not sleeping. And the kids will tell you that they hear gunshots in their neighborhood. It's not in their house, but they hear the noise at night, and they're afraid to go to sleep. We're seeing more trauma for teenagers, fear of going to school. More kids are refusing to go to school because of fear of what might happen to them at school. We're seeing a lot more kids presenting to our emergency departments who are reporting that they're feeling pretty hopeless and there's no point in being here. In addition to not feeling good and being afraid a good part of the time, because a lot of the kids are afraid of almost everything. There's the adult expectations that despite these traumatic events, that kids will just keep soldiering through and they'll be okay. You just have to do what you need to do. And many times adolescents, they don't want to talk to mental health professionals. And others that are around them who have relationships with them in their communities, their teachers, their faith-based communities, don't necessarily feel comfortable asking the questions. So what we're seeing, with prolonged untreated trauma, kids go on to have more anxiety disorders, more depression. A lot of the kids that we're seeing now who make suicide attempts have experienced significant trauma. And interestingly, in the last 3 to 4 years, the severity of the suicide attempts that I've been seeing, particularly in girls, is really striking. Previously, kids would come into the emergency department, maybe they took an overdose, maybe they did something, someone interrupted it. But now what we're seeing is youngsters coming into the emergency department who have taken significant overdoses, who are admitted to intensive care units that we are observing for liver failure. And this is not an unusual occurrence, it's a much more common occurrence, and we're seeing it more often in girls. We try to, on a preventive level, when we're aware of these situations, work with kids around how we address their trauma, how can we support their families in addressing traumatic experiences, and how we can help them move through these situations. But unfortunately, for many kids who, particularly kids in the inner cities, who experience a lot of trauma, they're multi-generational trauma. So the families have experienced too. There have been times I'm at work where I hear a family come in and say, this 9-year-old is just bad. And he's been bad for a year, but he wasn't bad before that year. And you ask, well, did anything happen that might have changed? And the response is, no, nothing's changed. You ask the child, and he'll say, I was waiting on the school bus and somebody was shot right in front of me. And then the mom will say, oh yeah, I remember that, but that happens all the time. So kids are living in a very different world. It used to be that the kids who were living in poor communities were much more likely to have these experiences, but now kids in every community are faced with the possibility of being harmed at school. And so those are some of the things we're facing. There are solutions. You have to have professionals with expertise, like Dr. Malone, in being able to help folks talk to kids about the challenges that they're facing. One other thing I did want to mention is that when we talk about disproportionate impact of these events on minoritized populations, I just want to highlight that for Black girls between 2010 and 2017, there was a 182% increase in the rates of completed suicide for that population. And so there is a disproportionate outsized effect of these events on vulnerable populations.
Thank you. I'm going to run out of time, so I will yield. Thank you so much for having this important hearing today, and thank you again.
Thank you, Rep. Lee, for your thoughtful questions, for prioritizing being here today, and our condolences on the recent loss suffered by your loved ones. I'm going to recognize myself for 5 minutes. First, I just want to say, I'm not going to call you Mary, I'm going to call you Miss Lawal, okay? Because you have presented and articulated in a way that I think you deserve to be addressed as Miss Lawal. Thank you for speaking truth to power. Thank you for sharing your lived experiences. I have no doubt that you're having done so here and in many instances prior will save lives. You are destigmatizing, you are healing, you are taking up space like the impressive young woman that you are, and you are creating it too. And for that, we thank you and we applaud you. Applaud her. Okay. So two quick things, and then I'll try to move here, though we're not being sticklers on time because this is all very important. But we want to respect people's time too. So, very often, and it's clear based on what we have learned here and what we're experiencing anecdotally, I mean, this is a very dire, everything that you've shared here is devastating and damning all at once. But I don't want to sit in the deficit. I think it's important that we have a North Star. So I wonder if you can just paint a picture, specifically when you spoke about the need for culturally, linguistically appropriate care. As one example, could you just speak to what is the North Star? If we were getting this right, if your community was getting this right, if your schools were getting this right, if government was getting this right, if your faith house was getting this right, what would it look like? How would you be able to access care? Who would be administering it? So give us the North Star, Ms. Lawal.
Thank you for your question. So I would say the North Star would be accessing care without any struggle, accessing care with ease, and I would say just not having people look at you differently, because in one of my experiences, when I opened up to my parents about what I was experiencing, and the first thing they told me was, where's your faith? What happened to your faith? They asked me, are you no longer trusting God anymore? And there are a lot of different experiences where people have told me in my background, my cultural background, that when they open up to their parents are like, where's this coming from? I provide food for you. I clothe you. I take you to school. You have education. So where is it coming from? And they tell you that you're selfish, or like you don't know what depression is. If you take it back to my times, you would know what depression is. Like, you don't know what depression is. So that's a lot of stigmatization that's going around in my community. But I'm grateful for my parents because they are now understanding what it is like to struggle with mental health, because I have taken it upon myself to educate and create awareness and just advocate for myself. And they saw how important it was for me to get the help I needed. And as well as it would look like just people not stigmatizing Black African American people, because I think there's this narrative that people of color don't get mental health conditions, they don't get affected by mental health. And I just want to put out there that mental health does not discriminate. You can get mental health regardless of your cultural background, regardless of your faith, regardless of your gender, what you look like. Mental health does not discriminate, and anyone can be affected by mental health conditions or mental health concerns. Thank you.
Thank you. Thank you, Ms. Lawal. And one last thing, just for the record, would you share again the Crisis Suicide Prevention and Mental Health Hotline that you find so helpful?
Yes, 988.
Thank you. Dr. Benton, I want to, actually this is for whomever would like to comment. I want to build upon something that Ms. Lawal spoke to, and it's the adultifying of our children, and disproportionately of our children that are managing multiple marginalized identities. We're doing everything possible to defend childhood, but we are failing, and our children are being adultified, whether they're being raised in grand family households, whether they're helping to care for younger siblings, working jobs, not for enrichment or for resume boosting, but because they have to. And then all of the layered crises we're navigating, as a country. What you were just sharing there about your experience with your parents, I'm reminded of a study that was done by our Boston Medical Center, and they asked parents on a scale of 1 to 10, how bad is your child's asthma? And they ranked it at a 3 or 4, but when they were tested, they were at a 9, 10. And so I use that as an example to say there's this weathering effect, and resilience is very overrated. And so I have two questions. Is while we're supporting, so Ms. Lawal is being a teacher to her parents, okay? But again, parents might not understand how adultified our kids are being in every way. Do we need to be also supporting the family holistically, because our kids are not independent contractors? So what does that look like? What is that model? Is it school-based health centers? What does that look like? And then my final question, and then that will end for my round, is I had a question around pipeline and retention, because if we do want culturally and linguistically competent care, how do we incentivize psychologists and therapists who themselves are managing multiple marginalized identities and who are burnt out and de-incentivized to also do this? So I'm just putting all my questions out there. Whoever would like to comment, please.
I'm happy to start. And to begin, I agree that it's about supporting the entire family and providing education to parents and caregivers about students' mental health needs. As Ms. Lawal said, there's this preconceived notion that you're a child. What could you possibly be depressed about? And so educating them about mental health, what that looks like within our youth. But also for a lot of our parents, they have their own unmet mental health needs. And so, as was stated by Dr. Benson, it's a multi-generational effect that they're coping the way that they learned how to cope, and they don't know any other way to act differently. And so when we support our kids, again, bringing families in and thinking about school community partnerships, how do we create schools that are a welcoming, affirming environment for families to come in, where they're invited as full participants? Because when we look at family engagement, there are a lot of barriers in place based on race and socioeconomic status. There's an expectation that you come in at the beginning of the school day or come in the middle of the day, assuming that parents don't have to work. Or there's a lack of childcare when there are family activities where they're discussing what is happening within the school. And then it's assumed that these parents don't care about their kids. And so there's negative stereotypes and messaging, not just about that individual student, but then the family as a whole, and that affects the school's treatment of that group. And when we look at meaningful school community partnerships, it's recognizing that parents have to work. We need to really think about removing those barriers to getting them in the door so we could provide them with education and empower them to be full partners within their child's well-being. And with that, thinking about what type of health services that we provide, providing them with resources and tools around their coping so that they are also learning new tools to model for their kids so that it's not the child's responsibility to teach the parent what they're learning at school. But those are some initial steps.
Thank you. Dr. Benton?
Yeah, I just wanted to comment that, the other challenge for parents when it comes to the children's mental health, people don't really teach us that we should ask our kids how they're feeling about things. And if we notice that they're doing things that are very different, like if they don't want to spend time with their friends anymore, they're staying in their room all the time, they don't spend time with their parents, they start to fail, we should be concerned that something's happening. But the other thing that we don't talk much about is for parents who have children with mental health conditions. I'm in a children's hospital. If your child has cancer, people bring you a casserole and provide you with support. If your child has a mental health condition, they blame you for doing something wrong. And the stigma that parents experience, the stigma that kids experience by having a mental health problem, and then there's stigma by association. And so, for families, they're coping with all of this. As mental health providers, we can do a better job of including families in our discussion about their children's well-being and kind of move away from this whole idea that the adolescent is my patient and the parents are just the people who bring them to the appointments and pay the copay.
Right.
The parents are tools in your treatment, and they have to be engaged in the children's care. And they have to learn how to talk about this, because when we were growing up, people didn't talk about things that happened to kids. And so families need support. They need role models. They need people to coach them. They need coaching. And many people can provide that. But we need to take a public health approach, and we need to teach other people in society, our other partners in the community, and I'm sure you can speak to this in your role, how to talk about mental health and how to tell people there's a 988 line you can call if you're feeling distressed. It really is the responsibility of all of us, and we need to share that responsibility.
I might add, Congresswoman, family support and family navigation is absolutely vital. As Dr. Benton was saying, we need to give families the tools to be able to understand what's happening so it doesn't become incumbent on our children to explain that to us. And certainly I hear frequently, surely you work at a mental health organization, you must know where I can find somebody to help my kid. If only it were that easy. So we need to provide navigation tools for families who want to do right by their kids but cannot find the help. It's just not out there. Having a 1 or 2 mental health professionals in a school is not enough. And schools often don't have the tools and they don't have the language to be able to navigate this as well. NAMI has programs that are about family-to-family support, teaching parents about what their child might be going through. We have a program called NAMI Basics. And there are lots of other organizations out there. Because there are such gaps in our system, it's community-based organizations working to try to fill those gaps. But everyone needs to be surrounded by a community that cares, and parents can only support their kids if those parents are supported as well.
Thank you. All right.
I was just going to comment on your question about recruitment. Yeah, we're really going to say that. So, there is definitely a shortage of diverse providers across specialties. And the only ways that we're going to start to address that is through some of the programs that allow the loan repayment, funding for underrepresented groups to be able to go through this extended training. I think actually we need to shorten training and provide other opportunities for young people. We do know that across the United States, the number of Black physicians is decreasing. And it starts at academic medical centers, which is where a lot of the work needs to be done in academic institutions. But there are ways to build up a diverse workforce. But it has to be intentional, and it has to be an institutional commitment, and it has to be a requirement that people pay attention to the needs of the patients that are being served. And that, I think, is probably a legislative issue that you could support.
Thank you, Dr. Benton. Okay, I need to get to my co-chair for her 5 minutes, so we'll transition. I know where to find you. All right, thank you, Doctor. Okay, all right, and now my esteemed co-chair of the Democratic Women's Caucus Policy Committee, Kathy Manning, for 5 minutes.
Thank you, Madam Chair. I want to thank all of our witnesses. Your stories and your expertise bring us important insights and information that will energize us to do the important work we need to do to protect our young women and girls and to work to expand the number of mental health workers we have around the country. Dr. Benton, I want to thank you specifically for listing all of those good bills that we should be supporting. If we get a speaker again, we can probably do that. And I want to mention that in my former life as an immigration attorney, I was able to help physicians use that Conrad 30 visa waiver program. And probably my favorite visa I ever was able to get was for a foreign national pediatrician to come work in a county that had only one pediatrician in the entire county. I had 3 young kids at that time, so I knew how often I called my pediatrician at night. Could only imagine the burden on a county that had only one pediatrician. So thank you for mentioning that important program. In addition to my role in this caucus, I serve on the Education and Workforce Committee, where I have had the opportunity to lead legislation on youth mental health. And everywhere I go in my district, from adults to teens to parents alike, they all tell me that mental health issues are a top priority because we are experiencing a youth mental health crisis. So to try to address this crisis and also to try to remove some of the stigma that we've talked about that students have in admitting that they have mental health crises or looking for help. A few months ago, I reintroduced my Improving Mental Health and Wellness in Schools Act, and this would ensure that schools, school boards, and other local educational agencies add mental health to their school wellness plans, rather than solely focusing on physical health and nutrition. And this would include increasing resources for mental health professionals. So, Dr. Malone, what are some of the other ways that the government can use schools as ways to reach young people, and how can we help individual teachers and school psychologists play a role in ensuring that students get the help they need?
Thank you for that question. Schools are a natural site to provide mental health supports, and for kids who receive public insurance, who are economically marginalized, and who hold racial ethnic minoritized identities, typically the school setting is the only place where they're receiving services. And so as part of the conversation around mental health, it's about building teachers' mental health awareness as well. Because we could have all of the service providers there, but if teachers don't recognize when a student is having a problem, they're not going to make that referral. And we highlighted the racial and ethnic disproportionality and racial ethnic disparities. And so when we look at teachers' referrals and identification of mental health concerns, we see difference there as well, where Black, Latinx, and Asian Pacific Islander students are significantly less likely to be referred for mental health services by their teachers if they have any internalizing concerns, such as anxiety or depression. But they'll be recommended for services if they're a behavior problem. And so as part of the initial conversation, talking to teachers about what mental health problems look like within kids, because there are a lot of kids who are being disciplined when they really should be supported instead. And again, that's on racial, ethnic, socioeconomic lines, gender identity, and sexual orientation. Another part of it is expanding the school-based mental health workforce and making it more reflective of the school population. Again, there's a critical shortage of school-based mental health providers, and the ones that exist are starkly different from the students that they serve. The school mental health workforce is overwhelmingly white, female, non-disabled, English monolingual. And when we think about the diversity among our school-age youth, it could be understandable why they may not go to a person because they don't see that provider as being able to understand their unique problems. They may not feel comfortable talking to a white clinician about their experiences of racism, or they may have had negative experiences with other school staff where they talked about issues of bias or discrimination and they were dismissed or they were ignored, and so that has taught them to be silent as well. And so when we think about expanding the mental health workforce, it's removing barriers. It is incredibly expensive and time-consuming to become a school-based mental health professional. There's high interest among those who are currently working within schools, but they often cannot take the time off, leave their jobs, and have that loss of income in order to enter graduate school and become school-based mental health providers. And even those who may be able to attend classes on a part-time basis, all of those programs require you to take internships. So again, there's a loss of income, and a lot of professionals can't afford that. That's why it's so important to support school-based mental health services grant program, as well as the mental health services demonstration grant, because those are supporting grow your own programs and providing the resources for school districts to be able to train those who are in the community, those who are already in education and want to expand their knowledge base and become mental health professionals, to be able to do so while keeping their jobs and being able to provide services within their district, and then formalizing university and school district partnerships where university training programs are receiving those grant funds. They're able to enroll more students, mitigate those financial barriers, and provide a workforce that's partnering with the district as well.
Thank you so much. You've given us lots of things to think about in terms of addressing mental health in the schools and expanding that workforce. And Dr. Benton gave us some good ideas of bills that will help us expand that workforce. So Dr. Benton, I want to turn to you and ask about how we can be protecting women and girls outside of school. And we know that social media algorithms can show extreme content to users, even content that promotes eating disorders, that adds to self-esteem issues. What can we be doing to ensure that teen girls are safe outside of the school setting?
Thank you for that complicated question. It's really around the issue, again, of community supports. And schools are community support in a much more proactive way. So I think that we need to expand our partnerships and education for others that come into contact with young people. So for example, people go to see their pediatricians. It's not stigmatizing. And pediatricians play a really important role around educating young people about their bodies and about health. Schools actually function in that capacity as well. And then one program that I don't think we take enough advantage of is school athletic programs and coaches. That group talks to kids. Kids talk to them about their problems, and we're doing a lot of work to try to educate, these athletic communities. And then the other one is faith-based communities. And the beauty of churches is that you don't have to be a member to get community support. And so those are opportunities to educate those individuals. The American Foundation for Suicide Prevention does an excellent job. They educate people in barbershops. They have something called Soul Shop, where they educate churches. They educate everyone to pay attention to potential for suicide and mood disorders. And we need to do the same thing with girls around their body image. We all need to be knowledgeable, and we all need to be talking with them. And so I think that we are going to have to take more of a public health approach to addressing the concerns that happen with girls. I think, unfortunately, several environmental events have made girls feel more unsafe, and they've shared that this fear, there's been increased violence, aggression, and much less openness to hearing about it. So girls blame themselves for bad things that happen to them. And we have to start to open up those conversations with families and other people who come into contact with children. And that would be a solution to addressing some of these concerns.
In all our faith houses, synagogues, mosques as well.
Thank you. And when you talk about coaches, I think that's a great issue to bring up. Let's also expand that to include the arts and music programs, because kids who are not involved in athletics, but who spend a lot of time in extracurricular programs that involve art and music, develop close relationships with the directors and the conductors, another place where people can teach about limiting the use of social media. Ms. Weslowski, the Republican fiscal 24 budget proposes steep cuts to Title I schools, Title IV, Part A funding for mental health support in schools, and for substance abuse and mental health services and for SAMHSA, the School Mental Health and Services Administration. Can you tell me what you think of these cuts? Are they going to help our situation?
This is not the time to cut investments in mental health. We know that our mental health challenges are only going to grow coming out of the COVID pandemic, world events, all of the things that are facing our young girls is going to have a continued impact on them. And it's going to take a long time to solve the provider shortages, to increase access to care. This is not the time to roll back that funding. Fortunately, we had record funding for mental health last year. Thank you to you all for your support for mental health funding. But we need to be investing and doubling down on those investments. Too often with mental health, we find good solutions, and as things start to progress, we just forget about it and move on to the next thing. And we never fully invest in those systems and give them the tools to work. We've seen that with community-based mental health services. We've seen that with so many tools in the past. So we really need to fully fund mental health supports at every level, in every community, school, church, pediatrician's office, wherever kids are, to make sure that they're getting the care and support that they need. Certainly any funds would have a devastating impact on helping our young kids.
Thank you. Thank you to all our witnesses for shining a light on these really important issues. With that, Madam Chair, I yield back.
Thank you. We'll now hear from Rep. Salinas.
Thank you to our co-chairs, and thank you to all of our witnesses. And I'm just going to start off by sharing my own story because I do think it's really important in this type of setting to share lived experiences and to destigmatize. And Ms. Lawal, I was very touched by your testimony. I was there with you. When I was 16, my younger sister attempted suicide, and she was diagnosed bipolar. And coming from a Latina family, a lot of it felt cultural in her recovery and in her seeking treatment. And so to your points about bringing the family in and finding cultural relevance in our workforce is so critically important. And whether it's linguistically or cultural, we are seeing a deficit. When I served on the Oregon Commission on Hispanic Affairs, when I was in the state legislature for 5 years, we did a study looking at providers across the state, and we had such deficits in some of our rural areas where nobody could offer services to my Latino communities, and it is just heartbreaking. Fast forward, I'm a mom now of an 18-year-old, and last year during, it was before the primary actually, my own daughter, who identifies as queer, had her own breakdown. This is somebody who has lived this and who has seen family members go through mental health challenges. I was shocked. Somebody who has talked to providers, talked to her pediatricians, and still did not see this coming. And so bringing the full spectrum of workforce into every setting where our female teen youth and all of our youth are is so critically important. So this is a priority for me. And I will, now that I'm here, I will take it to my district. The CDC report shows that Indigenous girls are disproportionately impacted by sexual violence. And this is a critical issue for me. The Grand Ronde Reservation and many tribal members are part of my community and located in the 6th district. So this really goes to our medical professionals and PhDs. How can schools provide culturally competent support for Indigenous girls and other young teens of color impacted by sexual violence?
Given the lack of diversity among school-based mental health professionals, it's incumbent that we're working with members of the cultural community as well. And so approaching our work with a humble approach, that we don't know everything about a certain family's culture and background, but it's incumbent upon us to work with members of that cultural community to give feedback on the interventions and the services that we provide, to talk about their ways of healing and being as well. Because for all cultural groups, and highlighting in your question, Indigenous communities, they have ways of healing that have been stigmatized within traditional medical settings, and then particularly in school-based settings as well. But bringing that in and not treating it as something separate, because when individuals feel like they have to put their culture aside, culture is a part of the human experience. How can we heal when you can't bring your full self to the therapeutic setting? And so again, working with cultural brokers, that's a primary key.
Thank you.
You know, one of the things that I think we have to think about when we're talking about treating marginalized and minoritized populations, particularly the Native American population, is going to require us to practice a little bit differently. And so our long pathways towards the PhD and the MD is not going to be the solutions to our problems. The reality is that we need to diversify the providers within communities. If we were able to incentivize people to stay in their communities, typically with education, we incentivize people to leave their communities. And the people that care about you and want to take care of you don't remain. And so it doesn't have to be the long pathway. There's the master's level pathway. There's also community workers. And we're really starting to explore how we can partner with community workers to create environments that are more comfortable. If we were able to develop education programs, associate degrees and other things that didn't require people to have to spend a lot of money, and if we can fund those things, that we can train people who can partner with the doctoral level professionals and others as needed to provide care in their own communities for the people that they care about.
Thank you. Oregon, unfortunately, which is where I'm from, has the highest rate of youth substance use disorder in the nation. And we know from the CDC report that prescription opioid misuse amongst teen girls is double that of teen boys. This is kind of a general question for the panel. Why do you think young girls are misusing prescription opioids at higher levels, and what potential federal legislation fixes could policymakers look at to address this issue?
So everything is worse for girls. When you look at the CDC report, every indicator was worse. And so the mental health is worse, and there's a strong relationship between trauma, mental health conditions, and substance use. And so for girls who are using more opiates and more substances, and in places where some of those substances are legal, it poses other challenges. And so that we would anticipate for all these other things that we're seeing, that we would also see a correlation between increased rates of substance use. And substance use treatment is complicated. And it's complicated in part because it really does require a multi-system approach. And so for girls, from my perspective, this is just one more indicator of how tough things have been for young women, particularly in the last few years. And I think the approach that's going to be required is the same one we've talked about for mental health, which is that it's going to take a community approach, a school-based approach, a family approach, using evidence-based interventions, because there are a lot of evidence-based interventions for substance use. But unfortunately, in communities where substance use is normalized, it creates, for young people, issues. Young people are much more likely to become addicted when they use substances. And so those are some of the challenges that we face around addictions treatment. But there are treatments, and young people can move through those.
I also think about the role of stigma. And so there's a lot, speaking of evidence-based interventions, there's a lot that could be done in schools as well when we utilize positive behavior interventions and supports. And many of the interventions on What Works Clearinghouse from the Department of Education that focus on behavior have also been shown to be effective for substance use. However, schools are very reluctant to say that they are doing programs that address substance use because that would suggest that there is a substance use problem in their school. And so instead, it's often treated as a disciplinary problem as opposed to recognizing it as a physical and a mental health problem, that it's a coping tool, a maladaptive coping tool that kids are using to escape from their circumstances. And so we need to actually provide them with alternatives instead, but that first requires us to acknowledge that this problem exists. And a lot of schools are unwilling to because of the stigma, and it's easier to discipline as opposed to admitting that they are a quote-unquote bad school.
Thank you. Do either of you wish to respond?
I was just going to add to what Dr. Benton said, that, it's a lot of the same solutions we're looking at. A lot of our young people are using substances to self-medicate and to deal with their co-occurring mental health condition. And so we really have to make sure we're looking at the whole picture, providing that mental health care that they need, providing earlier interventions and support, and really looking at why they might be using any opiates or other substances to, self-medicate or to address their situation. I think it's also important that the same report shows an increased rate of sexual violence against young girls, and that contributes to higher rates of substance use and suicidality, which is important correlation here.
Thank you. Thank you all, and I yield back.
Thank you, Rep. Salinas, and thank you for your candor and transparency on how this crisis has impacted your own family. And I hope your daughter's doing better. Okay. All right. I'm so proud to be a member of this Democratic Women's Caucus. I just want to say that. Okay, and now we'll hear from Rep. Chikuta.
Thank you. And first of all, just a big mahalo to co-chairs Pressley and Manning for doing this important shadow hearing as well, and for their advocacy. I will tell you this, that all of the testimony that you provided today really spoke to me. As a girl who struggled with my own mental health, as a mother and an auntie who goes home every weekend to see my sons and my nieces, and scared to death, terrified, like you said, about what what awaits them out there in the world, and will I be able to help them? Will I even know something is wrong? And as a community advocate who looks around me every day and sees the struggle, the disparities, the pain, and wants to help. And so, definitely today's discussion, you're speaking my language here, and I think you are among sisters and friends here who want to desperately do something now, and we feel the urgency as parents, as community members, as individuals who ourselves have walked in your shoes as well. I want to focus on 3 basic things real quickly and then open it up to you to respond, because so much good things have been talked about. But 3 things I'm passionate about. One is access into mental health care in rural and remote communities. Dr. Benton, you touched upon this a little bit, but I co-chair the Rural Health Caucus, and my biggest concern is on a regular day, every individual in our rural communities, they suffer a lack of access. We have workforces that we can't keep in our communities, and we try every which way for retention. We want to grow our own. We have access to care, even basic care, let alone specialized mental health care and services and providers as well. And so my biggest concern is how are we addressing the unique needs of girls of color, our LGBTQI youth, that are living in our rural and remote. Hawaii is in the middle of the Pacific Ocean, so if there's anyone who gets remote, it's my constituents. But they struggle every single day. And how are we going to help lift them up during these times? And how are we going to understand, as it was brought up in Representative Salinas' comments, the fact that we often need cultural navigators, because even within our own circles, we do not know how to deal with mental health. We don't know how to deal with the issues that we are facing. And so rural and remote community access for our girls is a big issue for me. The second, and was brought up a little bit by Representative Lee, is how do we help them respond to disasters and to trauma? There are shootings, but my district in Maui, we saw thousands displaced and homeless due to a wildfire. Almost 100, and it'll be probably over 100 dead at the end of the day as a result of this. Their schools burnt down, communities lost. We are talking about significant trauma where children right now shudder when the wind blows too strongly in front of me. There were kids who wouldn't go out of the ocean because they thought the fire would get them. Triggers that we are seeing in every single occasion. And we know that throughout the country, natural disasters, shootings, all of these things, these are traumas that go on beyond the time span of what we might even think is acceptable, these triggers. And so how are we helping to really understand and support our young girls in this? And oftentimes, sadly, what we see is these traumas and disasters result in other things. They have ripple effects. We see increase in domestic violence and abuse, sexual assault, substance abuse. So whether it happened to them or not, they are unfortunately victims as a result of these traumas and disasters. So how are we helping us as parents to be able to support them as adults in these youth life, to be able to support them? How are we realigning our training and pedagogy to be able to address this in the classroom and the school community? But this is sadly something we're not getting away from. We are not going to have less disasters and trauma. And now we need to know how to step up and support our young girls as they deal with it. And the third one, lastly, I hate social media. Sorry, hopefully this is not out on X anywhere. Social media and YouTube, we talked a little bit about bullying. But the big fear I have as I look at my nieces is this illusion of perfection. Everything is through a filter. Everyone is smiling and happy and everything. Life is not that way. Life doesn't exist through a filter. And so as we look at just the stress that our teens are, having to live with as a result of social media and YouTube, how are we helping them to cope with this? It's the illusion of perfection. To me, it's online grooming as well, as they somehow get this sense, listening to influencers, of what they should believe, their attitudes, their perspective on life. So we are no longer in control anymore as the adults in the room. It's the online influencers that are doing this. They're glamorizing negative behavior, whether it's self-hurt, whether it's suicide, whether it's substance abuse. How can we, without just turning off all the social media and YouTube on our kids, which I threaten to do every single day with my own children, how do we do this in a way that they can understand that there's real life out there? And how can we help them cope with the pressures and the strain that exist from this online presence? So that's a lot, but I throw this out at you as a mother and an advocate and a congressional mother, too, amongst many here that just cares about our kids and our young girls and how we're going to support them every step of the way. So not sure who wants to answer that.
Thank you for this question. So I would like to ask members of Congress to amend the HR 3713 3 Mental Health Services for Students Act, to where it caters to teen girls to have a quarterly mental health forum in schools. So I mentioned in my testimony that during a church youth retreat, that was where Silver Undom opened up about her experience and the burden she felt with her siblings at home. So I feel like just having these quarterly forums in school where teen girls can come and speak up, and not only speak up, but have professionals there to educate and let them know that mental health access and mental health care is an option. Because when I was younger growing up, I didn't know it was an option for me. I didn't, because people weren't talking about it. Like we mentioned earlier, people didn't talk about mental health that way. So I didn't even know that it was an option. I just thought, like, therapy was for just a higher class level. I didn't know that therapy could be for me. I didn't know that. So I feel like just having these forums in place to let teens know that it's an option for them, and let them know that there are professionals on their side that can help them and navigate life and their mental health struggles. And I just feel like this forum could be an outlet for them, because even at home, a lot of parents are in denial that their children are struggling. They're in denial and they don't want to accept it, because it opens up a new portal to discussion, and it makes them uncomfortable, because mental health is something where a lot of people do not understand, and they don't want to understand it because of ignorance.
Thank you.
There are a few things that I just wanted to mention. One, in terms of the ongoing trauma that our young women face, we as a country are starting to weaponize social emotional learning, and looking at that as something that should be, partisan, something that should be a difficult thing to implement. But we need to give young kids the tools to understand what's going on, to talk about, to verbalize, and to manage what they're experiencing. And that starts early. That teaching starts really early. And it needs to be integrated into our curriculum. We need to talk about mental health education as part of health education in every school district. It should not be the outlier. It should be a common aspect of every health curriculum in schools. And you talked about forums, and we have a program called Ending the Silence, and Mary is one of our Ending the Silence presenters, and it's about representation and having kids hear from other kids, having young women hear from other young women about their experience, and making sure that we're providing those opportunities to hear from somebody who has that shared experience with you, to say, I have been there, and there is another side. We can get through this. There are ways that you can get help, and this is what worked for me, and let me help you find the ways that will work for you. The last thing I'll say is that telehealth has been such an amazing tool to increase access. Half of our country lives in a mental health provider shortage area, 165 million Americans. Telehealth is a way to expand our workforce and reach rural and frontier areas. And we need to make the telehealth changes permanent beyond 2024. We still see such a high use of telehealth for mental health services, and it is such an amazing tool to bring access to so many people who've never had it before. So I'd encourage you to focus on making sure that's available. It's a tool that can be used in schools to connect kids to other community mental health providers that they may not be able to get out and see. It can be a tool that is used in so many ways. We've even seen law enforcement who come in contact with somebody in crisis use telehealth to be able to connect the person in crisis with a mental health provider. There's a lot of ways that it really improves access to care, and encourage you to find ways to make sure that that benefit remains permanent.
Thank you. All right. Thank you so very much. And if I could just add to the telehealth, telephonic, I always put that in as well. In some of our communities, telehealth isn't even readily available in our remote communities. So definitely telehealth, telephonic care is something that we definitely have to push. So thank you for your advocacy. Yield back.
Thank you. Now we'll hear from Rep. Dean.
Thank you, Chairwoman. I'm pleased to be here with you. And I apologize to the women at the table that I was not able to be here to hear your testimony, but my coworker was here, and she's going to fill me in some more. But I have read your bios and a little bit of your expertise and your experiences. I come at this, I think, like a lot of the women on this side of the desk, as a mom. My husband and I have 3 grown sons, and so their mental health, their physical health was something I cared an awful lot about when they were young and they were growing and developing and maturing. But they are now all married, and I have 4 grandchildren, the eldest of whom is an 11-year-old, almost 12. In another 2 weeks, she'll be 12. And she is, you can imagine, she is confident, buoyant, bouncing, curious, and I'm so fearful that somewhere the light will turn off, that somewhere she'll become more reserved, too worried about appearances and being accepted and all of those things, the pressures that young people are under. So I worry about her and her mental health. But I also come from a district, suburban Philadelphia, where, like so many districts, we went through COVID, and I saw the impact that had on our students. Our young students, our high school, our middle schoolers, our high school students, we're still grappling with that. And different school districts handling it, some fairly well and some completely under-resourced. People of color, students of color, struggling oftentimes in undiagnosed ways, unrecognized ways. And then my third level of experience is my middle son, Harry, is in recovery from opioid addiction. So I'm a big advocate around, we have a mental health and substance use disorder caucus, bipartisan caucus, and we know the extraordinary risks now of overdose. You don't have to be an addict like my son. I think of young people, we have to educate them as to the risk of fentanyl. You don't have to be an addict to think you bought a Percocet and be gone. And sadly, we have seen way too much of this with 300 people a day dying of overdose. So that's a big, rounded way of saying, I lift these issues up, tell our personal experience for some of the points you made, destigmatize, take the shame out of it for the person struggling with a mental health issue or an addiction or substance use disorder issue. And if we can tell our stories, stop the silence, or how ending the silence, as you said, other people will see themselves. When my son and I go talk, people come up to me inevitably and say, oh my gosh, our experience was so like yours, and I thought I was kind of on an island. You're not. What can we learn from the CDC report, from your experiences, about educating young women, getting them to access help and care and have the confidence, as I say with my granddaughter, have the confidence to raise your hand and say, I'm not coping well, I don't know what I'm doing here, I feel so insecure, or what are the best methods for us to do that?
So I wanted to say there are short-term and long-term opportunities. Some of the bills that are currently under consideration now would provide more access for young people to have more contact with mental health professionals in schools and in primary care practices. And the reason I talk about primary care practices, I mean, medicine drives about 10% of health outcomes. The rest of it is all social and environmental. But every child I've ever seen that I've asked them if they're feeling suicidal, have you ever used drugs, they tell you. So the times that they see their physicians, or their nurse practitioners, their primary care providers, is an opportunity for screening and identification. And screening is free, it's cheap, prevention works. But for most of the kids who are using substances, if you ask them, they will tell you every single time they've ever used anything. And so we need to start asking. And
my son didn't do that, and I asked him a lot, so I'm glad they trusted you.
So yeah, they tell me everything. They tell me everything, even when they say they don't want to talk to me. They tell me everything.
Interesting.
And the issue, though, is that for primary care providers, there's no reimbursement. And so their schedules are tight. Through collaborative care and the access programs, you give them immediate access to a mental health provider. And they can actually be compensated and paid for the service they're providing in primary care. Wow. And it's really important when kids are younger because they have frequent visits and they have frequent contacts with the healthcare system. But supporting collaborative care, the child psychiatry access programs, which are partnering with pediatric and other primary care practices allows them to not only be able to do screening and ask questions, but they can identify and actually have an immediate consultation with a mental health professional who can help guide them around what the next steps are. There's also opportunities for funding, for training pediatricians to do things like motivational interviewing, which is a common practice for youth who are using substances. And these are things they can learn, but they have to be compensated for the time that they're actually seeing patients to be able to provide those services. And so that's one potential option. We talked about telehealth. Telehealth is an option, but the reality is in some communities, people don't have access to broadband and they don't have access to devices. And we need to make sure that's actually available to people, because young people will call the 988 line, okay, and they'll tell people, you get guidance and counseling on the 988 line, but we can use technology to start to address some of these issues. And the substance use problems in this country is alarming with the number of deaths related to opioids. But there are things that we can do in some of the legislation that's already under consideration to support, expanded access to mental health care.
And I know I'm a little over time, but I wonder if, Ms. Lawal, you would want to add to that.
Thank you for this opportunity. So I wanted to add the 988 hotline. I wanted to add that there needs to be more crisis trainings going on right now, because children and teens are afraid to call into the 988 crisis hotline, and also just, call for help because they are afraid that they're gonna be Baker Acted. The Baker Act law, they get handcuffed and escorted to the mental health hospital by police officers. And I feel like those police officers need to be replaced by crisis intervention workers, because youths are afraid to call in and they are afraid to just have their trust broken, because these crisis counselors reassure them that the police won't be called, and then they end up having 3 police officers show up at their door, and more times out of 10, they're not gonna be calling in again. So I feel like just replacing the police officers with more crisis intervention workers.
That's excellent. Thank you very much, and I yield back.
I was in it, sorry. Okay. All right, and now we'll hear from Representative Wasserman Schultz.
Thank you so much. Dr. Malone, I want to focus on LGBTQ plus youth because they're facing an unprecedented assault in state governments across the country, mine being among the worst. I represent the state of Florida. And even in the U.S. House at the hands of the MAGA extremists that are, I can't even say running the place because they're not at the moment. So I want to, just to run through some stats from my state. 45% of LGBTQ plus youth in Florida reported seriously considering suicide last year. 73% of LGBTQ plus youth in Florida reported having depression or anxiety last year. 65% of LGBTQ plus youth in Florida reported needing mental health help but could not receive it. And 64% of Floridians aged 12 to 17 who have depression did not receive any mental health care last year. So, I mean, we really are facing a crisis, but especially for LGBTQ plus youth. So can you, Dr. Malone, talk about how this assault on our LGBTQ plus youth has impacted their mental health? Where can we direct, I sit on the Appropriations Committee, where can we direct federal dollars to support these students?
Thank you for that
question. If
question.
there's anyone else that wants to weigh in, feel free.
And thank you for that question. And it can be very understandable that LGBTQ youth, their mental health is under distress when their identity and their well-being is under attack, when they can no longer find books or images that represent them or stories that are resonant with their experiences that they could learn from. These all contribute to mental health distress. And so in addition to advocacy to overturn such laws like this, it's important for them to be able to see themselves reflected in the curriculum and in the library books. But it's also important to have providers that affirm and recognize that oppression is a source of mental health distress. And oftentimes, when we conceptualize mental health, we're going through symptoms of, well, what happened to you? Well, what is this discrete trauma? But ongoing oppression and discrimination and bias is indeed traumatic. And when it's occurring in school, a place that you're made to go to every day for several hours a day, they're being repeatedly traumatized. And so first and foremost, recognizing that it is indeed a traumatic experience and having an impact on their mental health and naming it as such, because when it's ignored, when it's treated as a non-issue, that's even further stigmatizing and further invalidating. And so as school-based mental health professionals, again, being able to recognize and call this out for what it is and engaging in broader advocacy efforts.
Thank you. And I mean, we even have on the books a state law that could, and even really likely, requires the school to out an LGBTQ plus student to their parents. I mean, that's the kind of trauma that the state of Florida under Ron DeSantis is putting our LGBTQ plus youth through. And you mentioned the mental health workforce. Is there anyone else that wanted to touch on that at all? If not, I'll just ask the next question. Generally, the state of mental health, the mental health workforce, which you all have mentioned, is struggling. I mean, I've seen horrific statistics of the ratio between counselors and students, and then just the really serious challenge, including things like licensing. So, I mean, a state like mine has always been very sort of jealously guarding who can be licensed for all professions, because we're a state that people like to move to or retire to. And, we have an advent now of telehealth and telemental health, which is really critical because that's expanded the access that anyone can have for needed mental health services. But I've even found with young people that I know that if their docket for appointments is very long. A lot of them don't take health insurance. So then, if you even if you have health insurance, many of them charge $250 an hour or up. So the financial inaccessibility to our youth is significant. There's the issue of, unless you tell your parents that you need mental health services, how do you get them? And then, of course, there's the fact that you can't be counseled in most cases, or in many cases, by someone who is not in the state that you live in. So I'm not really sure who best to direct this question to, but that's a mountain of obstacles for our youth to get access to mental health care, particularly our teen girls, who in middle school are particularly angst-ridden. So how do we deal with these? How can we as lawmakers deal with all those obstacles and help reduce the access problems?
So I would respond to a few of those because you raised really important issues. And I think we need to really support the laws, the legislation that support parity. And assuring that payment for mental health is on par with payment for medical health. And we need to enforce it because the parity laws have been in place for a while. So I think that's one issue around access for families. The other piece that you mentioned, licensing.
Now, when you say parity, so we did a lot of parity, and access to mental health care is covered in the ACA, but doctors don't have to take it. They don't have to accept health insurance.
Yeah,
so what do you do then?
Yeah, and it is a challenge that the majority of a large percentage, I won't say the majority, are in private practice and they actually don't accept any insurance. But much of that has to do with the rates of reimbursement because there's not parity. Yeah. And the other pieces have to do with the challenges of documentation with insurance companies and a lot of our policies around privacy. But those are things that can be addressed through legislative channels. The other thing that is an issue with telehealth is this practice across state lines and the restrictions that are also legislative issues. So during COVID, we were able to, you could see patients in any part of the country. And in underserved areas, you could actually provide telehealth access. Now, I work in Pennsylvania, I live in New Jersey. I can't see patients in New Jersey because I'm not licensed there. And so there should be some regional flexibilities that would allow you to expand access. And I think that would be a really important thing to address. And then, I think there's some issues around confidentiality and privacy that don't allow people to share information that are very complicated. This is especially true between schools and mental health healthcare organizations. And so the privacy laws with colleges, high schools, healthcare organizations they're important, but I think they need to be changed to be more beneficial for children and families. And so there's some things that we can do now that are sort of short-term gains. The last thing you mentioned about licensure is extremely important. And so I learned that in many states, there are limited employees in licensing bureaus, so things can't move quickly. So they move very slowly. And then I also learned that a very large percentage of clinical social workers actually never take the licensing exam because of the requirements for how long you have to have some clinical supervised experience. And I'm not even sure it's appropriate. But I think, at the state level, there's some opportunities to address issues like that would increase your social work workforce. Right. Some numbers have suggested in some states by 30% because of licensure requirements. So I think those work on that level can actually support access in many of these cases.
Thank you. Dr. Malone, did you have anything to add?
I would say that the similar issues around credentialing also apply to school-based professionals, and it is being addressed on the state level. I think about interstate compacts, and right now, school psychology recently was approved for an interstate compact and writing the legislation for that, but then having states sign on to these compact agreements. And so we have similar ones for psychology as well as counseling that will help that interstate practice because there's so many that live on the borders, being in DC, but if you're licensed in DC, you can't serve kids in Maryland or Virginia, even though they're right in your backyard. Right. And so supporting changes in our licensing requirements.
And then Florida is a peninsula. We don't really have a region. So that makes it even more challenging. Who do we link up with?
The issue you raise about, finding a provider is a huge issue that we hear about daily at NAMI. And I think there's a few ways to help. First of all, we're delighted to see the Biden administration put out new regulations around parity. Comments closed yesterday. We hope to see those rules finalized. But your colleagues in the executive branch need tools to hold insurers accountable because insurers have tools to make sure that there are more providers in their network. Ensuring network adequacy is a big thing. They can pay providers a lot more. That would certainly incentivize more providers to take insurance. There's been a lot of studies that have shown that mental health providers make less for the same exact billing codes than primary care providers. So why are we paying people who have one of the hardest jobs out there to so much less than other providers? So we need to be able to hold insurance companies accountable for what they're providing. And, I think that could give us a lot more in-network providers that we could seek. I think there's also solutions that we can look at from the state level that we could really elevate. Colorado has a program called I Matter. It has been a wonderful, wonderful tool that was started during the pandemic that basically gives young people 6 free counseling sessions. There's no co-payment, no co-insurance. Each year, 6 sessions where they can talk to a mental health provider. There's virtual tools, there's tools for parents. There are lessons like that we can take and expand on a larger scale to be able to grant more access without having to worry about, is this just a system for the haves rather than the have-nots? Is this a system that you can only pay for if you have the cash to pay out of pocket? Because right now it is, and we need to provide creative ways to work around that, as well as the tools to hold insurers accountable to really increase their mental health provider networks.
Thank you. Thank you, Madam Chair, for your indulgence.
Thank you, Representative Wasserman Schultz, for those thoughtful questions. And this has just been a very instructive hearing in many ways. So we will have lots of follow-ups legislatively and otherwise. Now we'll hear, and we do have to be mindful of time. I think we have to leave this space at 5:15. but I would love to invite Representative Gwen Moore for her questions.
Thank you. Just let me thank the co-chairs for convening this meeting. And I want to thank all of our witnesses for being here today. I am stunned at this CDC report. I want you all to know that I walked up those 3 flights of stairs to get here because I definitely wanted to hear from you. Now, before I ask my question, I just want to say something about you, Mary. Unfortunately, it's probably unfortunately, you fit into a stereotype of Black women that we just so resilient that we can just do it all on our own. We don't need any help. And it just looks like you did that too. I mean, that you were in crisis and you found the resources, that you were and unfortunately, I think that probably leads into the questions that I have for the doctors here regarding the dramatic increase in suicide rates and attempted suicide rates. Is it that folks like Mary have just been carrying this for generations or for decades, and that the expectations of the community are such that they don't even, that they've suffered from mental health issues and illnesses, but they never articulate it, they never seek help because there's the societal expectation that you just simply do it. If you got 5 siblings, you just have to get up an hour earlier so you can start combing the hair of the oldest one first. And that you never, so just let me shut up and sort of ask that question. Is Mary an example of someone who's been expected to be resilient, and maybe for her own inner resourcefulness or something, she just said, well, hell no, I'm just sick of being resilient. I'm going to find some help for myself.
Yes and yes.
She's a stereotype.
Well, everything that you said is absolutely true in terms of that expectation of weathering. And it becomes so normal that you don't realize that it's abnormal. If it's just the state that you're in, that, you mentioned that people don't talk about mental health crisis. And you have to recognize that you're in a crisis situation, that there's something abnormal or wrong with this. But if you've always felt this way, if the women around you have always felt this way and coped this way, it appears perfectly normal. Mm-hmm. But when we look at this recent data and our current circumstances, we have to consider the pandemic. We also have to consider issues of racial stress and trauma, because it's not just COVID, but the murders of George Floyd, Breonna Taylor, and seeing all of this play out every day on your social media feeds, and people being attacked for it as well. And so we hit a collective breaking point as a society. Something I do admire about our young generation is their willingness to talk about mental health. And I am in awe of what I see in schools across the country every day when students are protesting that they want counselors and psychologists and mental health professionals in their schools instead of cops. They recognize that the environment that they're in and the demands that are being placed on them to act like everything is okay, to take this test and sit for these exams, and then be disciplined when they're feeling, when their emotions are high, this is not right. And so they are speaking up against those pieces. But I think it's important to acknowledge, as Dr. Benson mentioned earlier, that this is multi-generational. And we have to break the cycles and point out that even though this has been normalized, the situation has never been normal and shouldn't have been treated as such.
Thank you. So, Dr. Benton, the suicide rate among Black females has increased by 182%. I mean, that's not, these are suicides, not attempted suicides. Is this drug-related? What accounts for that? What accounts for it occurring more among Black females than Black men? Is that something different? To what do we attribute that? And excuse me if you've answered this already and I wasn't here.
No, I have an answer. It's an excellent question. And, you know, we see increasing rates of suicide for Black boys and girls in different age groups. So we're starting to see increased rates of suicide for Black boys under the age of 12. For girls, it's during adolescence. And remember, when we talk about the data around suicide, completed suicide is a rare event. And so the numbers are small, but it's the second leading cause of death for young people, in part because not many things kill young people anymore. So we've cured cancers and heart disease and all other things. But the numbers are still significant because we're seeing increased suicide attempts among Black girls. And I think the factors are multiple, because suicide is usually not a one-cause event. It's usually a culmination of things that is triggered by something that happens. And at that moment, one makes the decision to take their own lives. And we know that about half of people who make a suicide attempt die the first time. So we don't have another opportunity. What we think are happening to minoritized girls and Black girls specifically are all the social and environmental factors we've been talking about: the increased violence, the increased aggression against them. And then I've had recent losses of 2 of my own colleagues to suicide, who were Black women who were professionals. And the issues really relate to consistent, stressful life events, exposures to microaggressions that people think are pretty harmless, and being blamed at times for major events that impact your life with not a lot of support in your environment. And all of those factors really contribute to what we're seeing in terms of young people's mental health, increased depression for young Black girls, which is associated with suicide. For Black boys, depression is not commonly associated with suicide. It's typically more impulse control disorders and some problem that happens in the family or at school that results in a suicide attempt. So there are multiple different factors based on age, but specifically to your question about Black girls, it is the environmental factors that we've been discussing that has just been worse for girls across the board. Substances, violence, all of those things are happening more to our young women in this country.
Okay, Madam Chair, I'm mindful of the time. I do have a question for you, Ms. Wazolowski, with regard to the CDC study and your notion, or your discussion of parity, mental health parity. My experience with funding or financing of mental health is that they'll say, if you're an alcoholic, you go in, they detox you for 30 days, that's it. That's the end of your eligibility for care. So what should we do here in Congress? I noticed that, how do we have an open-ended opportunity for people to seek the mental health services that they need and not have some notion that you ought to be okay in 60 days, or is that unreasonable? I know if you're Medicare, if they give you physical therapy and on that 91st day, if you're not walking again, then you're done, unless you have private resources. So when we start talking about parity and equity, what kind of timetable, or what sort of, how do we introduce the notion that this ought to be left up to the professionals, or it ought to be open-ended, or there ought not be these artificial not a single person gets done with alcoholism after you've thrown them in the can for 30 days. Am I right about that? Right around the time you dry out, your benefits are over and you don't have any time to get the treatment.
I mean, with any mental health or substance use condition, it's a lifelong journey. And what we see far too often is that insurance decisions about coverage are not based on a standard of care. They are based on other factors that are determined internally by insurance companies. If you have a heart attack and you go to a hospital, there is a standard of care that is generally covered, and you don't have to fight every single step of the way, most cases, for that care. For mental health conditions, they are complex, they are different, they impact everyone in a different way, and those decisions are not left up to providers to determine what care is needed. Far too often, I hear from families who have finally been able to have their loved one accept care, get them into a hospital, they actually have an inpatient bed that they can find for the person, and then insurance says, we're not gonna cover it. Sometimes you lose that opportunity because the next day that person may not be willing to accept care. And that's when we lose far too many lives. So these decisions need to be based on what providers say. What we can do is we can allow Department of Labor to impose civil monetary
There you go,
penalties.
because the chair is looking at the clock. The Department of Labor. Are there data really to demonstrate the loss of the work participation and productivity based on the dearth of mental health? We need that as ammunition to fight this fight, that there's a cost in not providing and making mental health interventions. Is there such a study?
There's a lot of data about the workforce loss and just kind of the, losing people missing work, being unable to work, and that cost. And I'll also note that the Kennedy Satcher Center for Mental Health Equity put out a great report on the cost of mental health inequities last year that talks about the loss of life, the loss of revenue, and there's a wealth of data in that report that gives us a lot of ammunition to fight back around why investing in mental health matters. There's not only an impact on lives, but there's a financial impact too. We save money in the long run.
Thank you, and I yield back.
Oh, no. Thank you, Representative Moore, for those thoughtful questions. Thank all my colleagues for your active participation, and thank our witnesses for sharing your lived experience, your expertise, and also for being instructive about where we need to go from an investment standpoint when it comes to our budgets and also as lawmakers. Maybe it's because we've been together so long or because it is an intimate space. I feel safe enough to share something myself. First, I just want to acknowledge that this is a shadow hearing being held by the Democratic Women's Caucus. It's a shadow hearing, and I will be partisan in this critique because of a Republican majority that is in disarray and disconnected about what really matters. And so this Democratic Women's Caucus has convened this shadow hearing. But our girls must no longer be in the shadows. I remember as a Boston City Councilor as a candidate running, saying that I was running to save girls that didn't even know they needed saving. And from my home community of Black folk, they would say, but it is the boys who are dying on our streets every day. And I said, I love them too. And it is our girls who are slowly dying right in front of us, for whom no one is speaking. This is not abstract for me. As a child who was experiencing vile intrafamily sexual abuse, and it seems being a girl in this country is a conflated experience with shame about everything. Shame about sexual assault, about abuse, about our bodies, about our queerness, about being undocumented, about being low income, about being disabled. We are constantly navigating shame. Two things saved my life. First, Maya Angelou's I Know Why the Caged Bird Sings. It was when I read that book that I knew for the first time that I was not alone. But Maya could not be my protector every day. And one of the reasons why I champion social-emotional wellness supports is because I am grateful for the intervention of a school nurse. I was not one of those children who acted out. I was a student leader and compartmentalized the many traumas that I was navigating while my mother was raising me alone and my father was in and out of our criminal legal system and I was experiencing this abuse. I was what you would call a frequent flyer. I was always in the school nurse's office, and it's not because there was anything physically wrong with me, but it was a safe space and place. And because she was trained and trauma-informed, I was one of those kids who didn't act out, but who shut down. And she said, I believe this child is experiencing abuse, and she needs help. So I want to thank all the providers, all the psychotherapists and school nurses and coaches and mentors and faith leaders who are actively listening and paying attention. And as I close, I also want to lift up Rio Allred, a 12-year-old girl living with alopecia like me, who was so bullied that she thought she had no other choice but to take her life at the age of 12. And so I think of her often, know that I am carrying the stories that all of you have so generously shared here. And I just want to make something very clear to every little girl in this country experiencing mental health challenges, battling oppression, struggling to find motivation, and looking for hope. We are truly representative leadership. We have all had our struggles and our battles. As a young girl, I did attempt suicide. And it's actually the first time I'm saying that publicly because I felt so emboldened to do so because of all the shame that has been pulled back in this moment by all of you. I just want girls to know that we, the members of the Democratic Women's Caucus, we see you, we hear you, we love you, and we're gonna fight like hell for you. This hearing is adjourned, and the work continues.